Despite the U.S. Preventative Services Task Force recommendation against PSA screening, we have come up with a novel algorithm to help doctors and patients understand the best way to be screened using PSA. So a patient is presented to a family practitioner, and during the visit, the family practitioner would order a routine lab such as PSA into the routine screening measurements such as cholesterol and lipids. So instead of the doctor always having to order PSA, it should be a test that occurs automatically at the physician's office. So if the patient's PSA is less than or equal to 1.5, we suggest that the patient return in 5 years for another PSA because he is at extremely low risk of harboring prostate cancer. Now, if the patient's PSA is at greater than 1.5, we suggest that the primary care physician consider referral of this patient to a urologist, at which point the urologist would order a test such as Prostate Health Index or PHI, Select MDX, PCA3, or the 4K test. And all of these tests are available to review on our website. If these tests come back as low risk, we would suggest that the patient go back to screening with his primary care physician on an annual basis until the PSA or other biomarkers come back as abnormal. Now, if these biomarkers come back as a high risk, then we suggest that the patient be seen by a urologist and receive a trust biopsy. Now, if the trust biopsy comes back negative, we would use a biomarker test such as Confirm MDX, which looks at hypermethylation of tissue to determine if there is an area or hotspot that was negative where there may be cancer in the prostate. And if this test comes back negative, we suggest the patient go back and be rescreened through his primary care physician. Now, if the test comes back positive on the Confirm MDX, we would recommend doing something such as a multiparametric MRI guided biopsy or a 3D mapping biopsy on the patient to make sure that there's no cancer hiding within the prostate. Now, if the patient is presented after a trust biopsy with Gleason greater than or equal to 4+3, we believe that this is something where we should consider treatment for the patient for their disease, depending on the patient's age, comorbidities, etc. Now, if the patient is presented with a low or intermediate grade prostate cancer, we suggest that the patient have more genomic biomarkers done on the actual tissue itself. These tests include the Prolaris test as well as the Oncotype DX, and these tests you can find more information on through our website. Now, if they are high-risk genomic markers come back, we would consider treating this patient for their prostate cancer because it shows a high-risk type of prostate cancer. Now, if the patient comes back as low risk, we would probably suggest having this patient on an active surveillance protocol, or perhaps even going back and doing a multiparametric MRI or a mapping biopsy to consider targeted treatment of the patient's lesion or lesions.